Good morning, everyone. Today, I am going to present an interesting case scenario. Here's a 56-year-old female patient who presents to us with complaints of generalized body ache and joint pain since last 4 years. She has mood changes, easy irritability since 1 year, history of constipation since 1 year, lived on laxatives. She initially presented to Department of Neurosurgery with bilateral lower limb weakness since last 5 months, which gradually worsened, and currently she was unable to walk since last 3 months. She also had a pain and swelling in left clavicle after trivial trauma, which happened 2 months ago during her scans. There was no history of pain abdomen or abdominal distension, no history of calciuria or urinary tract infections, no history of diarrhea or flushing, episodic headache, palpitation or sweating, no history of weight loss, fever or night sweats. Patient was evaluated in initially under Department of Neurosurgery, and she was advised MRI spine, which showed an altered signal intensity with soft tissue lesion measuring 24 cross 22 cross 33 mm, noted in the D4 vertebral body with the involvement of bilateral pedicle extending into the spinal canal. Similar lesion was found to be present in left seventh rib and left scapula. So neurosurgeon, they thought of on primary, so they asked for a PET CT scan. The PET CT report showed multiple FDG avid uptake in right tibia, bilateral femur, bilateral iliac bone, right scapula, sternum, and other vertebral site, including the dorsal vertebra. It also showed an FDG avid uptake in the left lobe of thyroid, measuring. There was no previous history of any medical or surgical illnesses. There was no known comorbidities like diabetes, hypertension, or pulmonary tuberculosis. She was a postmenopausal female. On examination, she was an elderly lady who was immobile, moderately built and nourished, and her power in bilateral lower limbs was 0/5. On examination, there was a well-defined swelling present in her left lobe of thyroid, measuring 3 cross 3 centimeter, which was just above the clavicle and about 5 centimeter below the angle of mandible. Swelling appears to be smooth, all margins were defined. So, our differential diagnosis was thyroid carcinoma with skeletal mets. Second was parathyroid adenoma, lymphoma, or multiple myeloma. On her biochemical evaluation, it was found to that she was having a PTH of 1114 picogram per milliliter, and her vitamin D was sufficient. Her calcitonin and CA levels were normal. Contrastingly, her total calcium and ionic calcium levels were rooftop. It is 16.2 and 7.2. Her ultrasound neck showed to be this is a lesion in her left lobe of thyroid, which is measuring 26 cross 23 mm, isoto hypoechoic, along with a lesion in a parathyroid adenoma, measuring 25 cross 12 mm. So guided FNAC we did from the thyroid nodule, which was Bethesda reported to be Bethesda 5 because it showed atypical cells in papillary clusters in colloid mixed with hemorrhagic background with variable nuclear size and fine chromatin. CT guided biopsy was done from the D4 lesion, which showed to have a giant cell lesion showing multiple osteoclastic giant cells amidst the fibrocollagenous tissue. The maybe scan showed a tracer avid lesion, which was just below the left lobe of thyroid, measuring 3.2 cross 2.2 centimeter. These are our maybe images, early and delayed images. So with a left STN measuring 3 cross 3 centimeter, FNA with the Bethesda 5, deranged calcium profile and concordant imaging, the plan was total thyroidectomy with left inferior parathyroidectomy. This was our post-op specimen, which thyroid weighed 10 grams and inferior parathyroid weighed almost 30 grams, which measured 4.5 cross 4 centimeter. Post-op histopathology of total thyroidectomy specimen turned out to be colloid goiter, and the parathyroid was a left inferior parathyroid adenoma. So this was post-operative monitoring. We can see that her PTH levels have significantly fallen down. Patient didn't have any signs of hypocalcemia, and she was discharged without any calcium supplements. Reviewing this rare literature, there are only 22 cases present in the literature where spinal brown tumors secondary to primary hyperparathyroidism are reported. The incidence is somewhere around 0.1 to 0.3%, depicting the rarity of the situation. So these spinal tumors have posed a severe diagnostic challenge to our patient. However, in Indian scenario, compared to the foreign scenario, Indian patients present to us with upfront to us with skeletal manifestation and brown tumor. So these were the differential diagnosis of the lesions with intraspinal metastasis, Brown's tumor versus intraspinal metastasis with multiple myeloma. There is a radiology picture depicting it. Here we can see the Brown's tumor, which is an expansile lesion present in the vertebral canal, whereas metastasis can be osteolytic or osteodense compared to the primary. Whereas myeloma has typical punched out lytic lesions, and the bone scan and the histopathology along with the bone marrow findings can differentiate the Brown's tumor along with multiple myeloma and intraspinal metastasis. So my taking message is intraspinal brown tumor can mimic metastasis. So this clinicians should always have a suspicion of Brown's tumor. Metastatic lesions can require MRI or PET-CT. We should also consider PTH testing to rule out Brown's tumor. Treating the primary hyperparathyroidism to regress the tumor and reserving spinal surgery for neural deficit can help in the patient's management for improving outcomes. Thank you.